Hi, it's Matthew Holt, and I'm delighted to be talking this morning with Francis Dare. Francis is in the global healthcare practice at Cisco, particularly in the Internet Business Solutions Group. So, Francis, welcome. And can you tell me a little bit, just to start off, who was it you were surveying?
Great to be here, Matthew. Thank you. It's great to have a chance to talk again. So, yes, a quick bit of introduction about who we spoke to and why we did it at this point in time. I start by saying that we've seen such a tremendous attention and focus on doing things differently in healthcare in nations for, maybe a last decade, a little bit longer. Your native land of England was one of the first to really undertake wide-scale change across the health sector. So as colleagues and I were thinking about that and starting to look to the future, we said, are we at another one of those tipping points in healthcare where we've had a wave of innovation and transformation, the stage is set to do some things differently or undertake some new ways of changing healthcare in positive ways going forward? We have some ideas about that, but more importantly, what are the leaders who really drive change at a national level across the globe, thinking and what's on their minds? Let's go ask them. And so indeed, you see here that we reached out through primary research to more than 100 leaders across the globe, 16 nations representing really just every geographic region, Africa, Middle East, the Americas, the Asia Pacific, and both emerging or developing economies and developed. So a really good global snapshot. We did that in partnership with Princeton Survey Research Associates International so that we could do this in part in 5 languages. And we reached out to folks who have the top level of responsibility in governments for the health sector and health services. So we think this is a unique piece of research, and we haven't seen anything quite like it. And more importantly, it does tell us that there's some very interesting opportunities in healthcare right in front of us to do some things differently and make even more positive change.
Cool. And before we talk about what those opportunities are, so you went really after the top folks, but in government, but in different types of systems, between sort of folks in the developing world who are, you would assume, have massively different problems and issues compared to sort of the US or even Europe or elsewhere. And obviously, just to state the obvious, Cisco is very international in the way it works, and so you probably have people in all these different countries doing different things, and there are obviously different layers of opportunities, but using all the vast array of technology that you guys bring to the table. So let's think a little bit about that. Why don't you go to the first couple of findings? But I think it's quite surprising that you've told me that in subsequent research, the findings are pretty similar, despite the different kind of systems that people are in.
Well, yeah. So, of course, when you have a diverse mix of countries, both from an economic perspective, a part of the world perspective, a cultural perspective, we wondered, and others wondered, can you get a real global snapshot, or is everything nation-specific or region-specific? And, in fact, when I went into the data and looked at regions of the world or developed economies compared to developing, I even looked at Commonwealth nations compared to the rest of the globe, I will say that the overarching key findings were very similar across the globe. Now, there are some things that tended to be more country-specific or region-specific. For example, when we asked about barriers to doing healthcare differently, adopting new approaches to health services or the health sector, those do tend to be more country-specific, and we saw that come through in our findings. But our breakaway findings hold together across the globe.
Yeah, that's I think pretty interesting, and I think just the first one there, equitable access to health services, the whole concept of, we've been talking about access, cost, and quality for years, and basically that's almost the first 3. If you think of efficiency, it's got a lot to do with, at least, if not cost, at least value. And then finally at the bottom, obviously, providing healthcare services that our country can afford. That's important to everyone, but you can imagine that, what that means in India versus what that means in the US is probably pretty different. But I think that's wonderful. And then I guess the other question is, what are they're thinking about problems and capacity, and I think you have a slide on that.
Yeah, so before we move off this one, I would make a couple observations. And you're exactly right, Matthew. You and I and a whole bunch of the folks we know have talked about cost, quality, and access for forever in our careers. What did strike us is the fact that efficiency for this group of 100 or so leaders across the globe came through as the thing they prioritized second as their greatest overarching concern. And of course, in healthcare, efficiency is people. The predominant resource in healthcare are people. So it was interesting to us that that's really climbed to the top. The other question I often get when we share this part of the findings is the question about affordability. And folks being surprised that 10% of the folks who responded to our question here said that that's really their top of mind concern. And I think there's a couple of explanatory views about that. The first is we heard in the in-person interviews, in particular in subsequent conversations, that value for economic investment is definitely a concern, that no matter what country you're in or what percentage of your GDP or how much you're actually spending on the health sector and health services, you want to get the very most for whatever that is, how large or small. And the other piece is that the top three care about, so to speak, are the ones that if you do well should help you control health spending. And so I think this is a reflection that very senior people who think about the health sector all the time from a national perspective realize you need to get to those root cause things that don't always work well today, and that if you do that, you should see a positive impact on issues of affordability and cost as well. And then you're right, Matthew, we do have another set of concerns around just day-to-day delivery of services. What are the toughest issues that these folks face? And you see on this slide the top three highlighted clearly. And then if I go on, I believe, we have the whole set of responses here to explore a little bit further. So I suspect you had a thought you wanted to offer before I go into
Yeah, well, I mean, so my sense here is that, number one with the bullet is maldistribution. Mm-hmm. And I would assume that, most of the world, wherever you are, I mean, there's two global factors, right? One is that, let's face the facts, the U.S. and Europe are sucking up doctors from developing countries in a way that's probably not sustainable and certainly not good for those developing countries. And the second issue is that within wealthier countries, and presumably within poorer countries too, the distribution between rural and wealthier urban areas is a massive problem. You just want to look at the distribution within the U.S. between different parts of the same state, or even within cities. Between the richer and poorer parts of certain cities. I'm sitting here in San Francisco, and until my new pediatrician, I'm about to adopt, moved into the Hunters Point Bayview area, the area of San Francisco with the most children didn't have any pediatricians, whereas the richer part of town over on the west had a boatload of them. And that kind of thing, I'm sure is very, is a problem that's been identified here in the first answer.
Well, indeed, and I think it's really important to highlight that while we often think of maldistribution as an urban-rural issue, it is very much an urban issue in and of itself as well. And if we in particular think of highly specialized practitioners, clinicians, physicians, those subspecialists, they're just not always going to be in a place physically with the patient who needs their expertise at a particular moment in time. So that's just a reality. And number two, no surprise, we've talked about shortages of certain types of healthcare professionals for years, and we will continue always to have a shortage of certain types of healthcare professionals, or just having them again in the right place. So that's an unending challenge.
Can I ask you, was there any variation between countries in that one? There's an argument about doctor shortages in the U.S. and do we have them or don't we have them? We've gone on forever. But, my assumption is that in developing countries, particularly in Africa and elsewhere, we hear these horror stories about how there just are no particular types of physicians in various areas, and there's very little access to even basic health professionals. And, we're seeing some work being done on that, obviously, from people using different types of technologies, even down to equipping the health workers with, SMS enables phones to answer stuff back, to answer back questions about maternal and child health in rural Africa. But, that seems to be, I assume that's some people this is a much worse problem than it is for, say, somebody sitting in Washington, D.C.
Well, I think it's different. I don't know that it's worse. You're spot on. I have a World Health Organization statistic in front of me, and one of their more current numbers is that there's a shortage of really almost 4.3 million physicians, midwives, nurses, support workers, the kind you were just describing. So I would say that in different countries, which kinds of providers are in shortage is different, but the shortage issue came through consistently. So it's just which kind of folks in which locations. The scenario you threw out is actually one that we explored. Later in the survey, we suggested some ways that on a nationwide basis, enabling technologies could be undertaken to support really big programs. And one of those was the idea of widespread support for community health workers who have basic training in basic care or education, hygiene sorts of skills, but you could augment those folks with online references, with connections to other more trained professionals so that you can expand the services at the local community effectively and scale them. And responses to that were quite positive, and that particular scenario did receive stronger responses from emerging economy countries than, say, example, it did for more developed economies.
On the other hand, you're seeing the U.S. even now just implementing text for baby. I'm thinking about maternal and child health at the moment for obvious reasons. For those of you who don't know, listening, my wife is about to produce her baby, but text for baby is kind of a developing country idea brought into the U.S. and has been very successful as an education campaign using simple text messaging, in the U.S. So great. So I think the piece that we sort of need to move on to is, why are you interested in this other than we're interested in the general issues, is what can we start doing about this? And you have some data about that. So why don't you say a tad about what you found in that area?
Yeah, and the common thread between the data we've just looked at and the answer that I'm about to reveal is the fact that typically we've tried to address those issues by moving people physically. We've tried to recruit doctors and nurses to other locations, or we've tried to get patients to move to wherever the healthcare services that they need are available. What came through in a very interesting way, and we'll look at break this apart in just a minute, is that when we talked about a 5-year time horizon, that's how we defined near term. And we said, let's just think very broadly about how we could do healthcare differently or health services differently, using a huge range of enabling information and collaboration technologies. What are the greatest potential approaches? And the one that came through is this idea that if we help health professionals communicate and collaborate with each other as people, have human-to-human connections, they can do a better job of diagnosing and treating patients. And we can address really all of those top concerns that we heard from in the first two questions. So this is just so very interesting for a couple of reasons. Let's spend just a second here, Matthew, calling out what's important here. So at the top, you see in equal numbers, 62% of the folks who responded said that the top 5-year time horizon opportunity is helping health professionals share data, data from electronic health records, images as well from electronic health records. If we think about where the emphasis has been, where the investment has been, where all of the attention has been in recent years, it is that focus on data sharing and electronic health record adoption. The second piece that's just equally important and comes through loud and clear is the one I just highlighted, that you have to help the people of healthcare connect with each other in live conversations, share expertise, figure out diagnosis and treatment together more effectively. And so we think there's a need to balance attention, investment, and understanding of the people part of how healthcare gets accomplished and delivered with that data exchange piece. And then with that as well, you see that clinical training and reference materials being available helps everybody stay current with best medical practice, and that was just 1 percentage point less in terms of our respondents, the number of respondents who said that's a near-term priority. I will reflect on this. You brought up the idea of text messaging and those sorts of opportunities, and all of the options on the page, and that was one of those, what you see a little bit further down. That text messaging idea is, in terms of consumer-facing services, the thing that is the near-term greatest potential as well. Over half of the survey respondents highlighted that as something that can be done and have very real positive impact. Remote patient monitoring, the idea that you can have devices and that people at home or at work can have their biometric data supplied to a clinician to know how their health status is. This tells us it's a little bit further out. I think we still see potential for that, but for a variety of reasons, that's less immediate as an opportunity than the things I've highlighted at the top here.
Yeah, I was actually pretty struck by this, and I was struck by my experience wandering around the KP Center for Total Health, which I think you've seen in D.C. as well, where there's a bunch of your company's equipment scattered around in there as well. Was that, you know, we think a lot about patient to consumer, consumer to physician connection using these tools, and I think that is really great potential. But of course, you know, a lot of it is to do with, okay, you're a health professional, you have a patient sitting there in front of you, and you need help. And even in developed countries, I mean, we either send people down the hall or more likely across town for a specialty consultation, and we don't know if they're available. We don't know how to set it up. We don't know this. We don't know that. And I don't know if it happened at the end and what the result was. And often there's a breakdown there. And if you can put somebody onto a communication device right in front of you, as I think you guys are working with the folks at Kaiser in the Mid-Atlantic to do, you know, you can imagine that the pop you get out of that instant communication and the help, I think is really substantial. If you surround that with data, as mostly is happening in these systems now, you're doing so collaborations of both using the technology to be talking about stuff, but also be sharing data as well, which is those first 2 points. To me, that's a huge opportunity that, you know, to this point, I don't think any developed nation has really started using well, let alone thinking about, you know, rural telemedicine collaboration and that kind of stuff.
Well, so that's exactly right. I'd add just two quick examples to that. Think about how physicians train. They spend several years in medical school absorbing a ton of information. We could think of that as the data part of their training. But then as interns and residents, they go to hospitals. They make rounds as a group. They present cases in front of each other. With attendings, they talk about symptoms and figure out what diagnoses might be. So that's how these folks are trained, and then they go into practice, often as primary care providers, you know, alone or in a small practice. And they're on their own. So they do lose that piece of collaboration, of expertise sharing. And we also know that the real gold standard for especially specialty care for scary things like cancer is multidisciplinary team care. And if you go to a cancer center, you're going to have that whole team with you in person. Well, we can enable that best practice care now when those healthcare professionals can be in a whole bunch of different locations and still serve patients who have high-cost, high-risk conditions efficiently.
Great. And in terms of what this means sort of more systematically for the type of development of these services, you know, we've been talking backwards and forwards about how these are going to develop. There's obviously reimbursement issues in the U.S. in particular, but, you know, I guess the question is what happens next. You've now got a slide up here about National Centers of Excellence as kind of a way of sort of, you know, moving this into the workflow, if you like, of everyday providers. Talk a bit about how you think this is going to play out in the next 5 years.
Yeah, exactly, Matthew, because we want to see tangible change happen, right? We're about making things, we want to move the needle, not just have interesting conversations. So we had a number of findings that spoke to that issue. One thing that came through loud and clear across the whole world was the reflection that we've had lots and lots of pilots and what might be called small pilots. One of the top, 3 to 5 things that need to happen, according to these folks, is that we need to see if these new approaches can happen on a wide scale. So you could start on a national scale. For some new approaches, you might want to do it on a provincial or at least statewide level, but we need to get beyond those smaller pilot projects and prove that this really can be done in a mainstream, big way. And in fact, we did explore, as I had said earlier, some different scenarios that said, would you as a leader in your country consider some of these approaches viable as a new national program to do some things differently. The one that resonated with the best positive response was this idea of a national center of excellence. So you could take the most skilled, most highly trained people around a certain kind of care, you could say pediatrics, or a certain kind of condition, we could imagine diabetes. And if that set of clinicians could be available across the country to support other care teams in local communities by consultations, by being part of clinical research together, by being part of clinical encounters without, moving physically, that could that be done? And does that seem viable to you? And you see here, 84% of these respondents said, yes, we could do that. Now, that would be done differently in different countries. In one very large country in South America right now, we're actually working with the primary pediatric hospital in that country so that they can reach out to local communities and extend the services from that one existing National Center of Excellence. In another country, you might imagine that, their version of a National Institutes of Health, where you have just super skilled, trained people who are researching at the cutting edge of treatment, could be virtually available as to share that expertise. So it would be done in different ways, but it seemed very viable to the people that we spoke with.
Yeah, it seems to me that you've got the potential in all these, especially in some of these developing countries, to sort of build a new system, and if hopefully you don't have some of what we've had here, which is sort of turf battles between local, regional, national, and some of the differences that have occurred in sort of treatment patterns. We know about the variation in care and what have you, because we don't necessarily have the best information in the right place, and we also have different incentives between different types of organizations in some of these specialty care areas. Cancer is a good example for doing different things. So you can imagine that the technology might help leapfrog some of these, get some of these countries past some of these problems, and we're going to certainly be thinking about that here. Give me a sense. I mean, and obviously all the things that you've got on the chart here regarding surge capacity and helping telehealth-based services to do surge and to get information to community health workers and all these different kinds of things. You can imagine all these things really being helpful. But let's get to the business case for it. From your sense, is this, are we at a tipping point? Are we likely to see Cisco and its competitors and other people with different solutions finding, a lot more interest than we've seen past these pilot stages in the next little bit? Or do you think we're, how hot a button do you think it is for these government ministers over the next, little bit, few years?
It's a great question, and I'd say that's where we do see some variation as well. So one of the things we heard from leaders in a large Asia-Pacific country is they have a national agenda towards moving to team-based care, multidisciplinary care, and doing that in an efficient way. But they don't, obviously, again, they don't want to have all those medical professionals in one location. So I think the clues or the indicators are where you have something that's a national policy priority, where part of the country's health strategy speaks to some of these issues, then those are places that are ready, and we'll see some of this take off faster than others. If we think about the U.S., we'd love to see the Beacon Community model that was funded by grants under high-tech become more widespread as in the states we move towards accountable care organizations. The recognition that not only the exchange of data from electronic health records, but actually working together in new ways and delivering services to patients in new ways is critical if you're going to achieve the real goals of accountable care organizations. But we're realists in knowing as well that the top conversation these days is mostly about how do I get my electronic health record to meaningful use stage 2. So it's more of a complicated conversation in the U.S. And I think. So
let me ask you that, because you spend a lot of time looking at these sort of policy and regs about this. And I've had people tell me on the one hand, the accountable care organizations, are going to be the greatest thing ever for telehealth and remote care systems, because it's like it's in the regulations that have to happen. Well, other people tell me, well, it's really not clear once they're outside rural areas whether they can get reimbursed for that or what have you. And what's your sense of how much the current set of interim regulations are promoting? I know it's a bit off topic from your study, but how the interim regulations for ACOs are going to promote the use and adoption of remote telemonitoring, telehealth that we've been talking about.
Well, I think everybody's still figuring that out, and I would say the first thing I would think of when I think of accountable care organizations isn't so much extending patient services into different locations or doing remote monitoring. I think it's the care management piece that would enable the primary care provider, who may be the patient-centered medical home anchor, the home care agency that's affiliated with that ACO or belongs to the hospital part of the health system that's part of that ACO, the folks that are hospital-based in delivering services across that ACO patient population. First of all, you just have to get those people talking to each other and managing across that continuum of care. And the patient's part of that, right? But we have to care manage efficiently and effectively as much as we need to deliver services in different ways. So, I think of telehealth very broadly, Matthew. It's a whole range of enabling technologies for sure, but it's a very broad range of different approaches to healthcare. So I think one of the important findings of this study is that we so often think of telehealth or telemedicine as a point-to-point interaction where a clinician and a patient are in different locations, and we're just extending care to a location where it couldn't have been delivered without that enabling telehealth technology or care model. We need to think more broadly about what these different care approaches can be. We need to think about multiple people in multiple locations coming together. We need to recognize the need for collaboration amongst care teams and their patients. And indeed, for some patient populations, we do need to manage them more proactively in the home as well. So I don't think there's going to be one ACO model, and the draft regulations don't dictate one approach. What they do drive to is a particular outcome or impact, which is cost savings and better quality care.
Great. Well, I've been talking with Francis Dare, Director in the Internet Business Services Group at Cisco, in the healthcare group there. Francis, thank you so much for your time. It was good to hear what you've been learning from your survey work with all those healthcare leaders across the world, and we'll look with interest as you keep rolling out new products and keeping us informed on what's going on in the world of telehealth, business and regulation. So thanks a lot for your time.
Always a pleasure, Matthew. Thank you.